So hi, everyone. Thank you so much for joining this session. Again, for people who don't know me, I'm Diana Carvajal. I am new faculty here. And I was asked to talk about my work. So what I decided to do was talk about patient-centered contraception care, why it matters, and how we can do it. I will just give a little bit of background by saying that, I've been working in contraceptive care delivery and trying to figure out really the most useful for patients, but also for clinicians, and frankly, the most humble ways of delivering care and supporting patients to make decisions that they know are best for them. The work has definitely evolved over time, I will say, as I've had really the support and the privilege of getting to dig really deeply into this work and the work that others have done before me. So I start with that as an opening because that has really shaped the teaching that I've done, both in my previous job as Director of Reproductive Health, in the residency where I was, and also the research and the clinical care that I do. And also anytime that I talk about this work, especially this topic of patient-centered care in contraception, I find it important to share my positionality, right? So just to let folks know where I see myself situated in this work. I am a practicing family physician, and I've spent a great deal of my clinical career delivering and teaching this work with patients who have the capacity for pregnancy, who have uteruses, and I've really tried to center all of my teaching and my clinical work in that. And I am a cis woman. I am a cis woman of color. I am a Latina, and I bring that lived experience to this work. And so I think that's important because the lenses that I share this work from really matter to me and are definitely affected by my positionality, my communities where I grew up, and the generations in my family that have come before me. So we'll start with that. And so the broad objectives of this talk, so I'm going to start by defining and discussing patient-centered care, or PCC, which I'll say for short, in the context of contraceptive care provision. And I'm going to spend, full disclosure, going to spend a lot of time providing historical and contemporary context for how broadly reproduction and reproductive health has been managed in the U.S., starting from way back from our inception, and particularly how marginalized communities have been treated. And I'll talk more specifically about how these broad approaches have really informed contraceptive care provision and delivery. And then we'll get into the delivery of care and what the research really shows. Who wants patient-centered care? Who gets it? Who actually delivers it? And who doesn't? And what the challenges and inequities are with respect to delivery of patient-centered care. And then lastly, I'm going to describe some strategies for how when I say we, I mean we, clinicians, researchers, public health workers, all health professionals, right, within our clinical systems, how we can deliver this care and subsequently maybe measure patient-centered care so that we can actually provide it. So just stepping back, what is patient-centered? Some people say person-centered care. What is it? We talk about it and we use the term a lot. I feel like I've heard it so much nowadays in healthcare. So what does it mean? And so this is just kind of a word cloud that I put together of what PCC is. These words are from existing literature. It's also from my own work. And I think that these descriptive words really embody what patient-centered care is, but it also reinforces that patients and their contexts matter, and that we as people in healthcare, I think, really need to understand these contexts in order to achieve patient-centered provision of care. But here's the OG, or the original definition from the Institute of Medicine, right? And so the Institute of Medicine says that patient-centered care is providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. And the IOM has recognized patient-centered care really as an important dimension of quality care. But digging more specifically into contraceptive care, what's patient-centered contraceptive care? And so in practice, PCC generally is focused in some very important tenets. First, it's the elicitation of patient preferences at the forefront, right? So asking people what they prefer. And then it's about evidence-based information exchange based on those preferences that people share with you. Hopefully, at this point, we all know that it includes compassion in care, and then also skillful communication, which is a really important and core tenet and component of PCC. And these all apply to how contraceptive care is delivered, both in counseling and actual provision. But also within the context of contraception care and counseling, a patient-centered care framework is really going to bring to our attention and urge equity by insisting that healthcare systems and the clinicians that are in those healthcare systems really meet a person's contraceptive needs across a continuum of care. And moreover, contraception care, and we'll get into this in the next couple of slides, understands that patient-centered care framework really has to focus and recognize that there are historical, social, political, systemic, community, and familial factors that really affect how contraceptive decision-making is done in the U.S. It's really about accessible care and also autonomous and equitable care for all the people. And so why is contraceptive patient-centered care important? It matters because it's associated with improved outcomes that we all seem to care about very much. But also, it's important because people have the right to maintain dignity and autonomy in contraceptive decision-making. And I mentioned that specifically because there's context. There's important, unpleasant history in the U.S. that is really crucial, I think, for us to account for as we deliver this care. It's unfortunately not necessarily only in the past. In fact, a lot of this historical context, I think, and I'll argue, is really deeply connected to the contemporary context of how contraceptive care is delivered. I also think that we can use these lessons in this historical content to really, the historical context to really look to the future and think about how we can do more equitable care. And so I'm going to really push us over the next few minutes to visit some of this historical context. Maybe for some it's the first time, and maybe for some we're revisiting things, which I think is never a bad idea, to really think about what the history tells us of our past and our present. Okay, so if it's not clear, history matters. It informs the present, and I really always find it crucial to spend some time reviewing. I'm going to give you some concrete examples of why the history of how reproduction and reproductive health in this country, especially with respect to communities of color and other marginalized communities, is really important for how we deliver patient-centered contraceptive care. And so I'm going to do a select historical overview. I'm going to talk about very specific instances in history. It's not comprehensive by any means, and if folks are interested, I'm happy to share a much more comprehensive resource with folks, but I will be covering a few topics. They are unpleasant, and so those 3 asterisks there are also to remind me that this is a trigger warning. Some of this stuff is really unpleasant. Today might not be the day that you want to hear this. So if that's the case, then this would be the time to mute me or get up and walk away. So we're going to start from taking it back from the beginning, 1619 to 1865. It's a lot of time. And in the history of our country, I'm going to say this a couple times, it's more time than not, right? More time than not. We know that people on the African continent, particularly the western part of the continent, were forcibly brought across the Atlantic and enslaved. And it goes without saying, but I'm still going to say it, that there were incalculable offenses and abuses on reproductive autonomy, on bodies and families. During this time, we're talking about rape, forced pregnancy, separation from and subsequent sale of people's children, and forced neglect of their own children to care for those of slave owners. It's not to say in any way that somehow these abuses ended in 1865, because we're quite aware that they didn't, but it's important history to remember and truth of facts that I think we need to not forget in the context of how we're delivering reproductive health. In 1840s, and we could say closer to the time of emancipation, and I'm sure hopefully many of you are familiar with the man and physician who, up until quite recently in modern medicine, we called the father of modern gynecology, J. Marion Sims, who spent a lot of time developing a treatment for fistulas. That treatment came at the expense of experimenting on enslaved people without their consent and without anesthesia. 3 of those women who were experimented on, now known as the mothers of gynecology, are famously named Lucy, Anarcha, and Betsy, if people are familiar with those names, because of what they, against their will, gave to modern medicine. And like those women, there are countless others whose names are either not known or actually have been lost. In the 18th and 19th centuries, we're going to move to talk about indigenous populations. But when we think about what is now called the United States, we know that indigenous populations were specifically targeted. Traditional among indigenous populations was at that time that a feminine person was often at the center of communities and was viewed and treated as a leader of the community. And so these were the very people who were targeted during this time, a very concerted effort to devalue feminine leaders, often by either religious mercenaries and missionaries or colonial government officials and representatives. They targeted people specifically to usurp power and would arrange, so for example, forced migrations during very brutal weather conditions that targeted pregnant people in particular and forced them to travel under harsh conditions, especially during labor, circumstances that were very purposely created to interrupt traditional birthing practices and rituals. And we know that during these forced migrations, many died along the way, to the point of what has been written about and referred to as a clear genocide. From 1920 to 1980s. Okay, so in the 1920s, this is when we start to see the rise of eugenics and its policies. And these policies were very specifically aimed toward people who were deemed as having either physical, psychological, cognitive disabilities. Disproportionately, they included people of color. And these policies and laws held that these folks, right, were not entitled to full human rights and instead needed to be managed by government agencies and representatives using these eugenics policies. Ultimately, we end up seeing that these laws allowed for 60,000 sterilization procedures in the U.S. And this happened at state institutions, mostly. And again, the people who were sterilized were disproportionately Black, Indigenous, and people of color, immigrants, and LGBTQ plus communities as well. And I have here Mississippi appendectomies because relatedly during this very same time period, we know that thousands of low-income Southern Black women were also subjected to involuntary sterilization procedures. They end up being coined Mississippi appendectomies by Mary Lou Hamer, who was a very famous civil rights activist. Hopefully folks know her. And it was coined this way because physicians during this time were operating on women for unrelated reasons, like an appendectomy, having your appendix out, or having your gallbladder out. But physicians would use the opportunity during this time to sterilize women without their consent. In the 1940s and the 1950s, this one's close to home for me, and I have it specifically up here because it's about sterilization and fertility contraception. And so on the island territory of Puerto Rico to this day remains a commonwealth, a territory of the United States. People in Puerto Rico are American citizens. During this time, the government on the mainland United States led a sterilization campaign for what they called population control. They targeted folks who were having would have sterilization procedures and be consented either during labor or they would be completely unconsented. This campaign leads to this very impressive statistic that I always keep in my head, which is that by 1965, 35% of the entire island of Puerto Rico in people with the capacity for pregnancy had been sterilized, and 2/3 of them were in their 20s. And in tandem with the sterilization campaign in the 1950s, when the oral contraceptive pill is coming to the American mainland market and people are excited about it, even think that it's a little bit liberating, what we know is that these pills are first tested on folks in Puerto Rico without consent and before being declared safe by the FDA. There were a myriad of clinical trials for these contraceptive pills that were performed on Puerto Rican people who were living in housing projects, medical students, and using levels of estrogen and progesterone, which are the hormones found in many oral contraceptive pills, at 20 times the eventual acceptable levels, right? And so you can imagine that they created significant harmful side effects, included but not limited to infertility. Okay, I'm going to end with this last point here, which is also that during a similar time period, the 1920s to the 1970s, the 1970s just happened, I feel like, right? I was alive, so not that long ago. We know specifically that Mexican origin women, for example, and people, other Mexican origin folks with the capacity for pregnancy are sterilized without their knowledge or were consented during labor, not in their primary language, at a very prominent U.S. Academic medical center, UCLA Medical Center. It happened at the hands of residents and attending physicians, and also happened in conjunction with unconsented research related to other contraceptive methods, including the oral contraceptive pill. There's a documentary about this. It's called No Más Bebés, if you're interested in taking a closer look at that. And so, okay, so I know this is a lot, but I share this information, these tidbits really in the course of our history, because I think it's a reminder. Maybe it's new info for some, but I think that it really should serve as a reminder about what's happened with respect to reproduction and contraception in the U.S., who's been targeted specifically throughout our history, and how there's been a very concerted effort to limit and interrupt the reproduction and childbearing of very specific people, and people who are ultimately believed by the dominant society not to be worthy of having children. I think we have to keep that in mind as we think about the care and reproductive health, including in contraception, that we deliver. And what we also know is that history doesn't end, right, in 1970, but its legacy continues to contemporary times, and specifically with respect to how more modern-day contraception has been rolled out and to who and for whom it has targeted. So in the 1970s and 80s and 90s, we start to see fertility, right, really come to the forefront in medicine, right, in terms of controlling fertility. But also it starts to come to legislation. It comes up in legislation, fertility as something to control. And we see with the advancement of contraception that specific people and communities do get targeted, right? So let's talk about the first long-acting contraceptive method on the U.S. market, which some of you might remember in the 70s and 80s. It was the Dalkon Shield IUD, which is short for intrauterine device. You can see it here pictured on the left. So one of the first IUDs approved for use in the U.S., we know it was a polyfilament. It had a polyfilament string, and ultimately it does get associated with higher risk of pelvic infections. Ultimately, it gets pulled from the market and ends up because it causes significant side effects. But initially, when it first comes to the market, it is marketed specifically toward low-income folks, particularly Black and brown people, and ends up causing enormous reproductive harm, including sepsis, uterine puncture, infertility, pelvic inflammatory diseases. And again, it disproportionately happens in low-income communities of color. Relatedly, when we think about another contraception method, which is DEPO, we see it come to the market in the 80s. It comes to the market, it comes to the U.S. and is administered in public health clinics. And first is administered to what are called, quote unquote, mentally impaired Native American women. And they do this prior to FDA approval. And so there's a pattern of bringing contraceptive methods to low-income, marginalized populations, right, before bringing it to the full market and before the FDA actually approves it. In the 90s, a couple of things happen. We see the Norplant. Some of us might remember that. It's another long-acting method. You can see it on the right side of your screen. It becomes popular. But what we should know about the Norplant, which again is eventually pulled from the market, is that it comes as an incentive to reduce or avoid incarceration in mothers at the time who had been accused of substance use. And it's really focused on that population of people. And so in this time period, now we start to see legislation really also come up in terms of legislative proposals and policies that also make public assistance benefits contingent upon contraception use. And I bring all these things up about contraception because I think it maybe it triggers me, but maybe should trigger others to think about how it's legislators are involved, social scientists get involved, medical professionals often get involved in creating policies, right, about fertility, about contraception, and that there's some strong beliefs here about who should be having children and who should be parenting and who shouldn't, right? People who are quote unquote mentally impaired, people who have substance use problems, people who are on public assistance, right? And these policies and beliefs, I think they really underpin even very modern day proposed legislation and policy. And I'll share some of that with you on the next slide. So these are more modern proposed legislations and actions. They're much more recent examples. These are actual headlines of either legislation or attempted legislation that's related to fertility control. And it's mostly using sterilization and contraceptive methods, right? And so, for instance, in 2008, we can see that in Louisiana, there's a lawmaker who proposes paying public assistance recipients $1,000. Right? So you're on public assistance. I'm going to give you $1,000 if you have a tubal ligation, so get your tubes tied, or you have a vasectomy if you have a penis, right? And right. So please don't have any more children because you're on public assistance. And at the same time, that same proposal proposed tax incentives for college-educated couples to have more kids. In 2006 to 2010, I feel like that also just happened. We know that infamously California prisons sterilized 148 prisoners who were pregnant while they were housed in the prison. And there's good evidence to suggest that they were coerced into accepting the procedures because sterilizations normally required approval from medical officials that was never obtained. Disproportionately, the people who were sterilized were folks of color. 2017, there's a Tennessee judge who offers to reduce jail time, again, for people who either use a contraceptive implant or have a vasectomy. And then in 2020 just happened, right? We know this is a fourth example. Maybe folks remember this, but this was a nurse working at a Georgia ICE contracted facility, ICE's Immigration and Customs Enforcement, who was the whistleblower, right? And reported that at least 15 folks who had been detained in the immigrant detention centers were pressured into unnecessary procedures that included hysterectomies. And so we just can see persistent efforts, right, to either force or coerce contraception use or sterilization in our legislation and our penal system. And in the work I've been doing, it really can say this is my opinion, right? But I do think that this actively undermines and devalues the childbearing of some and effectively, right, encourages or forces even childbearing on others. And it's just, I bring these things up again just to demonstrate that people creating policies have really strong beliefs, right, about who should have children, who is parenting, who's not. And it impacts our patients, right, who have generational knowledge of these abuses, and that these things have been passed down through families and through generations. And we can see it manifest as very justified mistrust of the medical system. The beliefs, right, like these beliefs and these policies, they not only impact, right, how we see and how we talk to our patients, but ultimately they end up shaping policies, clinical guidelines in some cases, and even practices in how people actually receive care. So this is an example of some of our policies. And so notably, I would say for at least the last decade or so, at least in reproductive health spaces, there has been a strong push to promote long-acting methods of contraception. We see it come up in guidelines and policies and practices. This is from the CDC and the OPA, the Office of Population Affairs, a 2014 Quality Family Planning Services Guide. These are some clinical guidelines. Disclosure, those asterisks are there because they've recently revised these guidelines. They came out in 2024 and they're now being fully revised and shared. But I bring up the QFP because I remember this being such an important document when it came out. It was really well read. It was highly anticipated in the sexual and reproductive health community. And it it encouraged provider assessment of patient preference, right? So seemingly very much in line with patient-centered care. And also, if you continue to read the guidelines, it encouraged the use of a tiered effectiveness approach. The tiered effectiveness approach, right, is that we start with the most effective methods first. That would be LARCs, the long-acting methods, the implant and the IUD, and that we bring those up first and we really talk about them and focus on them. And in some cases, only focus on them when we're doing contraception, counseling, and prevention. And so if you think about patient-centered care, right, we can say like, yeah, this tiered effectiveness approach could be problematic because it's definitely prioritizing effectiveness. It may be coming from the viewpoint or the priorities of a healthcare clinician or from the healthcare system itself. And it's questionable whether or not it's really centering patient preferences because it's encouraging clinicians to focus on LARCs. Ultimately, it ends up leading to either perceptions of or actual coercion, right, to use LARCs over other methods, and really, never really accounted for the fact that we have this history and there are centuries of medical abuse and mistrust of marginalized populations. And so, we can see here that the historical context and this history of reproductive violence, legislative policies, they have their ways of permeating into our policies and clinical guidelines, even if it's not intentional, right? And I know that when these guidelines, they first come out, they were really about supporting and increasing contraceptive access for patients, but it hasn't always been so equitable or just, and frankly, least of all, patient-centered. And we can see, I think, how our clinical guidelines can now show up in inequities in practice for what's actually happening and what patients are telling us they're experiencing, right? For historically marginalized community, these are just a few examples, but the data tells us a few things. So first, we know that compared to their white counterparts, Black and Latina patients with the capacity for pregnancy often feel coercion into picking specific methods, usually the LARC methods, that they're more likely to report having shorter contraceptive visits, and that at times they feel that clinicians want to restrict their childbearing specifically. Yeah. We know that among LGBTQ plus patients, that 1 in 3 trans patients are turned away for healthcare, including sexual and reproductive health, but especially contraception. We also know that folks in the LGBTQ plus community report discriminatory comments and treatment and a lack of provider competency, frankly, specifically related to sexual and reproductive health, but that includes contraceptive care specifically. And in patients with disability, we know that those of reproductive age report a significantly limited quality of care with respect really to all sexual and reproductive health, but specifically to contraceptive care. And so if we're looking at this data and we don't have that historical context, right? We can say, okay, marginalized communities, yes, this is happening. They're experiencing coercion. And that's what it is. It's coercion. And it's a lack of provider competence. But it's deeply entwined, mingles, I think, with our history, right? And with generational trauma and our history of violence and concerted efforts, sometimes by government officials and government sanctions, right, to really focus on the fertility of very specific populations. And so in healthcare, right, by extension, how we learn and the systems that we operate in, we're not exempt, right, from being a part of these systems and even carrying out some of the very same inequities and oppressions that we hope, right, and that we claim to be against, whether it's intentional or not. And so, again, why does any of this matter for those of us in family medicine, for anybody who's working with patients? What's the takeaway? The takeaway, I think, as I think about this work and I've thought about it for a long time, is that access is important, right? Obviously, we must provide access, but in isolation, it's insufficient without autonomy and equitable opportunity to make choices. And that's where we come in, right? We have unique opportunities to expand access and support our patients and mitigate the inequities that shape people's experiences with the healthcare system. And that we know when we do this, right, when equitable justice-based sexual and reproductive health is accessible, right? That picture, that entire picture, that's when people and their families and their communities can thrive within the healthcare system. Also, ACOG, the American College of Obstetricians and Gynecologists, say we should be doing it, right? So they have put out guidance and recommendations on contraception counseling and provision, and they really are highlighting a patient-centered framework, which I think is important. I've circled the two that I think really focus very much on patient-centered care, which is, again, acknowledging that historical and ongoing reproductive mistreatment of people of color and other marginalized individuals is a thing. And within that, to prioritize patients' values, their preferences, and lived experiences in the selection or discontinuation of a contraceptive method. Okay, so all of that, I talk about patient-centered care a lot in contraception care. What do we know about it? What does the data tell us? The first thing we know is that patients want it, and that's true across a variety of clinical settings and demographic characteristics. We know that from clinician perspectives, clinicians support it. They say they support it, and they really endorse the value of contraceptive patient-centered care. But what clinicians do in practice may not necessarily reflect the general support that they have for it, or a solid understanding of what patient-centered care is and how to apply it in practice. So this first study, it's from 2022, and they looked at the extent to which clinicians practice patient-centered care during contraception counseling and provision. And what they found was that when people came in to request LARC removals, right, what we would call early removals, so before the time that they're supposed to be removed, people clinicians expressed a great deal of resisting. And people were actually refusing, these clinicians were refusing to honor patients' request. And that would include not only delaying removals, but just flat out, right, refusing to remove these contraceptive methods when people ask for it. This is one of my studies. This is from 2021. And this specifically is a study that we did focusing on the provider perspective in terms of providing patient-centered contraceptive care with Latina patients in Baltimore. We looked at we asked them, right? Like, how do you counsel? What does it mean for patient-centered care? And how is it specifically related to the Latina patients that you're taking care of? And what we found was that while clinicians very much talked about the importance of patient-centered care, they seemed in support of it. In the same sentence, they would tell us about how they used shared effectiveness counseling. And they did spend time trying to convince, quote unquote, convince people to keep methods longer. And as the first study showed, they did a lot of delaying and even refusing of removal at times. And effectively, we're really focused on the importance of prioritizing pregnancy prevention above all, right? Even at the cost of true patient-centered care, and even if not consistent with what a patient had expressed to them. And so what we ended up seeing was this tension, right? It's this expressed desire to provide patient-centered care, but it's in contrast, or maybe it's in competition with what I would call a very paternalistic style of counseling that really prioritizes pregnancy prevention even above patient preference. And so overall, the data, and there's a recent article I have it cited here from Johnson from 2024, that clinicians seem to offer patient-centered care. They try to, and they try to focus on, and they even validate patient experiences and integrate them into counseling and method selection. But at the same time, there is explicit communication about and actually honoring patients' contraceptive priorities is actually quite rare. This is an example of a clinician quote from my 2021 study when we asked providers how they feel about implementing patient-centered care with Latina patients. And this clinician says, I always make sure that they know we can always take it out. And she's talking, they're talking about a LARC. They can take it out if they don't like it. But I typically do encourage them to keep those for commit to keeping them for 6 months. And then we'll kind of work with the side effect issue, because sometimes I put them in and then I have girls come back 2 weeks later and they're like, yeah, I have been bleeding for 2 weeks. And I'm like, no. So in the paper and how we wrote this up, we use this quote as an example of the tension, right? This desire and willingness to provide patient-centered care, but at the same time, right? Sharing with us that you're kind of engaging in a relatively coercive practice, right? Somebody has side effects, they want this out, and you want them to keep it for 6 months, and then they can come back, and then you can talk about side effects, and then maybe you'll consider taking it out, right? So that's an example. Here's another example. This is a quote from the same study. Again, we're asking about patient-centered care in Latina patients. And this clinician says, I feel like a patient who has a malpositioned IUD and has to go to the OR, or the operating room, because it wasn't able to be removed in the office. They'll be like, oh, my IUD was in the wrong place and I had to have a surgery. Where it really, it was an outpatient kind of procedure. They had good birth control for the 5 years. And as a clinician, I think that's actually not the worst outcome. So again, we use this quote in our paper to illustrate the tension of providing care, right? And this paradigm of we want to prevent pregnancy prevention above all. And this person doesn't want an IUD because it got stuck and they had to go to the operating room and they had to take it out. And that's not really a big deal, right? So it's also like this trivializing of, a person doesn't want this, but it's really good birth control. And, going to the OR wasn't that big of a deal, right? So I think this is in pretty stark contrast to patient-centered care and to having an understanding of patients' experiences. So what are the barriers of patient-centered care and contraception, right? And so this is what the literature tells us. Some of this is also my own work. This is not exhaustive by any means, but I have tried to put them into 3 buckets. And I'm sure many of us have experiences, right? This first bucket is really at a systems or clinic level, right? Like time constraints during our visits, inadequate patient insurance coverage of the methods that they want, scheduling challenges, and all the costs that are associated, particularly with long-acting methods. These can interfere with patient-centered care. Then there's this group that's at the clinician level. So there is racial and ethnic discrimination between clinicians and patients. There's also a clinician resistance to new practices, right? Like doing patient-centered care, and even clinician misconceptions about contraception and what people can and cannot have. And then finally, in this third group, these are things that Diana, particularly refers to as being patient attributed. They've been named by the health system, by researchers, or by clinicians as barriers, but they attribute these barriers to patients. And some of my work has noted specifically, for instance, that clinicians will specifically name language discordance between them and the patient as a barrier. Now, that doesn't play out when we ask patients about this, but it's still something that clinicians name and attribute it to patients. They also attribute low patient education and low health literacy to patients, especially low-income patients, especially patients of color and those whose primary language is not Spanish. Although, again, the literature, my work is not consistent with that. Patients typically have a good understanding of their methods, particularly when they have clear communication with their clinicians and know what they want. And then finally, there's this idea that patients have all these misconceptions, or what clinicians often call quote unquote myths, right? About birth control, right? And really find the need to focus on dispelling these myths. For instance, the myth that birth control pills or other contraceptive methods cause infertility. And oftentimes, particularly with the work I did with Latina patients, clinicians would often call this a cultural misconception. They would say things like, Latina patients, all of us broadly, all the Latinas in the whole world from all the countries and all the different experiences have this cultural idea that birth control pills cause infertility. One, it doesn't play out in the literature, but two, it also, I think this is where I really will push back on understanding and having a clear understanding of our historical background and our precedents, in thinking about that some of these misconceptions about modern day contraception might actually be rooted in historical truth, potentially generational trauma about acts of reproductive violence, right? And people might not know specifically that their communities were tested on, right? But it somehow has made it to them, and they have a mistrust of the system. And it's not something that's necessarily attributable to a very broad culture of people, but maybe is rooted in historical trauma. So what can be done? What can we do? I know I'm getting toward the end of this talk, and I'm saving this for the end. But I really thought that history was important. So I'm going to talk about what we can do individually and then maybe what can be done on a systems level. So ultimately, I'm going to say this about 1 million more times, but patient-centered care in practice, in the context of clinical care, is understanding that access and isolation is insufficient without autonomy and really equitable autonomy to make choices. And that's what we can do. We can support patients to do that. It sounds really easy, but in my experience, and the literature bears out, we're not actually doing that, right? What does it mean in actual practice? So first, I think, again, it's understanding the historical context, and we all need to do the work. If this is the first time that you're hearing this, this one little talk or reading one little article probably isn't enough, but it's constant work that we have to do to remind ourselves of this context and to learn things that maybe we never knew before. It's also about trust and communication, and I think we all know this, but it's about really letting the patient lead these kinds of business in this case, because they really do know more than we know about this for them. We can listen, we can believe, and we can trust people. And that trust is so important, right? Build the trust the way that you would want it for yourself and think about the things that you need to have in order to build a trusting relationship with a clinician. And it's not just about having people trust us, right? But it's about giving people, I think, a reason to trust us. And communication goes a long way, and listening and believing really goes a long way. And then, as I talked about, because the main tenet of patient-centered care is focusing on patient preferences, but it's focusing on their preferences, I think, within the context of lived experiences, which means that we have to ask them and elicit from patients what they want and what they need, and then give them that. And it means that we listen more. Maybe we talk less and we hear them. And it really, I think it's also a judgment-free zone where you try to take your own judgment out of this as well, and really focus on communication, which is a core component of patient-centeredness. And in doing so, we really think about engaging in evidence-based, non-biased, non-coercive, full information exchange, right? We're answering people's questions truthfully. We're giving them information based on what they told us their preferences are. We are not downplaying potential side effects. We're telling them they can get their LARC out whenever they want to get it out, that we're not going to convince them to keep it, that there are alternative options, yeah? Hopefully, we're all doing these things, but sometimes it's hard to not judge people or to think to yourself, oh, I already know this person, I know their quote-unquote story, right? But we can work, we have to work intentionally, I think, to avoid typecasting people based on a whole host of things: race, ethnicity, gender identity, age, class, ability, all of these things. People have their own unique context and lived experiences. Respecting and supporting folks through the course of their care, even when they make choices about sexual and reproductive health, about contraception that you wouldn't make for them or you wouldn't make for yourself, is really important. And that often includes accepting that people are going to decline information, they're going to decline to use methods, and that's okay. We can still support them in that. And then lastly, hopefully is what we're doing a little bit today, but thinking about your training and retraining in comprehensive patient-centered care. And how we can really root that in historical knowledge and precedents. And a lot of this stuff is simple, right? It's obvious, but the research tells us that people aren't getting this care, especially marginalized folks, and that we have room. In our healthcare systems, I think we can all support, train, and implement and measure patient-centered care. I'll talk more about that on the next couple of slides, but we can really talk about training people and supporting that in our clinics, addressing the gaps, visit time constraints, scheduling issues, and again, continuing to train ourselves, our staff, and all the people in healthcare that we work with, thinking about same-day contraceptive services, emergency contraception, LARCs, vasectomies. How can we get these in the clinic? How can we advocate for over-the-counter contraceptives that are easy to get? And then also, how can we measure whether or not we're actually doing patient-centered care? Okay, so how can we measure it? Hopefully you believe that patient-centered care is important in contraception care, and also want to think about how we can measure it and address the gaps. So there are a few different ways to measure it, but I'm sharing this measurement with you because I've used it in the past, and I like it because it has been validated across a varied population of patients across race, ethnicity, across clinicians, facilities, and it is validated in English and Spanish. This is called the PCCC, or the Patient-Centered Contraceptive Counseling Measure, and it's a performance measure that really assesses how patients experience patient-centered contraceptive care, and it can be used actually to inform quality improvement and enable clinical practices to really enhance equity in the provision of care. I know you can't see the questions right now on the right, but I'll share it on the next slide. And again, I think this is really important, and it's specifically designed for prioritizing patient-centeredness in contraception care and helps us identify gaps. So here's the PCCC a little bit bigger. It's 4 items. It asks about whether or not a patient feels like they were respected, like they could talk about what mattered to them in contraception care, whether their preferences were taken seriously, and whether or not they had enough information to make a decision. And patients can answer on a scale from 1 to 5, corresponding from 4 to excellent. In psychometric testing, this measure is scored dichotomously. It's either a top box score versus everything else in that top box score. The benchmark is that a person answers excellent 5 for each one of these, and then that score is compared to all other scores. And so in the near future, I'm just going to tell you in my little bit of time what I'm actually doing. And that is that you might be saying to yourself, this is all great, but how do I actually do this? Right? Like, thank you, Diana, for all your foofy and fluffy talk and advice, but I need some clear, concrete algorithms for how I can do this. And so that's what I'm working on. My research is really focused now on a point of care tool for clinicians. It's for clinicians, not patients. And people sometimes have a hard time thinking about that, but this is for you as a clinician to use. And it's really designed to facilitate patient-centered care during contraception counseling. It's based on 15 years of qualitative and quantitative work that I've done with both patients and clinicians, and listened to lots of audio recorded visits between them. And I really try to account for what the known barriers of patient-centered care are. So that's time constraints, the need for brevity, but also have a grounding in historic and current inequities, and really help the user follow an algorithm of what patient-centered care is that helps you focus on asking people their preferences, giving them evidence-based information, and helping them make the decision based on that. It's a tool that I can share it publicly, but it's being piloted and refined right now. And I will share a screenshot of it briefly. So this is it's on paper right now, but it is also available in a PDF like clinical app as well. And just to give you an idea about it, it starts off with some broad assumptions, like you know a person wants to talk about this and that you're not making that assumption. It also goes through some important tenets of you need to connect with the patient and then elicit preferences, then counsel and make a plan. And so it leads you down an algorithm allowing you to understand what a patient's preferences are, whether they know what they want or don't know. It allows you to also counsel them, and it gives you some prompts as well. And it also gives you some common pitfalls and reminds you that maybe you have to worry about trivializing side effects, coercing people, and things along those lines. And then these green boxes here, they kind of, you can click on them and it gives you more information. It gives you language you could use. It sends you to the medical eligibility criteria. So that's what I'm working on now, more to come. The future is a clinical trial. So in the future, if you're interested in testing this out, you know where I am. Please reach out. I know I talked a lot, but I want to thank everyone, and hopefully we have time for questions. I have a bunch of references, and for anyone who wants resources, I'm happy to share those as well. Thank you.